Hello, I'm Dr. Tarek Badr, veterinary consultant at Giza Memorial Institute of Ophthalmology. Today I'm going to present a quick quiz about some retinal cases. This is our first case. Colored photo of 33 years old female complaining of left sudden diminution of vision. Describe the lesion. What's your diagnosis? What are the investigations to be ordered? What's your treatment regimen? If our female patient is pregnant, this will make difference in your treatment plan? Let's go to the first question. Describe the lesion and what's your diagnosis? Of course, this is a colored photo of the left eye. I can see two focal retinitis besides old pigmented scar. My diagnosis is active toxoplasma retinitis. What are the investigations to be ordered? About the ocular investigations, I will order OCT to determine if our macula is involved or not. About the systemic investigations, I will order anti-toxoplasma antibody titer, IgG and IgM. What's your treatment regimen? We should know first our patient is immunocompetent or immunocompromised. In immunocompromised patients, we treat all lesions. In immunocompetent patients, we treat only the site-threatening lesions. And here, this lesion is site-threatening as it involves the papillomacular bundle, and also this lesion is threatening the macula. So in both conditions, we will give treatment. But the difference will be in giving systemic steroids. If our patient is immunocompetent, we will give systemic steroids in addition to one or more of the anti-toxoplasma antibiotics like pyrimethamine, sulfa, clindamycin. While if our patient is immunocompromised, we will not give systemic steroids and we will give only antibiotics. The fourth question: if our female patient is pregnant, this will make difference in your treatment plan? Of course. If our female patient is pregnant, the drug of choice will be spiramycin or azithromycin, as most of the antibiotics are contraindicated during pregnancy. Also, about the systemic steroids, we can consult the gynecologist about the validity of the systemic steroids according to the general condition of the patient and the trimester of the pregnancy. As the systemic steroid during pregnancy is not absolutely contraindicated and may be given in some cases under supervision of the gynecologists. Also, in pregnant females, we have another option of treatment is to give intravitreal injection. Intravitreal injection of clindamycin and dexamethasone. This intravitreal injection, we will get the benefit of controlling our disease, and at the same time we will avoid the too much complications of systemic treatments. Next case: fundus fluorescein angiography photo of 60 years old male complaining of right sudden diminution of vision. Describe the lesion. What's your diagnosis? What are the investigations to be ordered? What's your treatment regimen? For how long would you like to follow your patient? First question: describe the lesion. What's your diagnosis? This is fundus fluorescein angiography of the right eye. We can see here dilatation and tortuosity of the upper temporal veins. We can see also collaterals and areas of capillary dropout or capillary non-perfusion. My diagnosis is upper temporal branch retinal vein occlusion. Okay, we can see here also hyperfluorescence increasing all through our angiogram to form flower petal pattern at the late photo, indicating cystoid macular edema. What are the investigations to be ordered? Again, we have ocular investigations, will be in the form of OCT to determine the thickness of the macula or the thickness of the center of the fovea, to determine the presence or to detect the presence of cystoid macular edema, and also to evaluate the vitreomacular interface. About the systemic investigations, we have to search for the cause or the underlying systemic disease, like diabetes, hypertension, hyperlipidemia. Okay, and if all these investigations are not yielding, we will go for searching for the less common causes, as collagen diseases, myeloproliferative disorders, hypercoagulability states, and other miscellaneous causes like renal failure, hypo or hyperthyroidism. What's your treatment regimen? First of all, we have to control the underlying systemic condition. Then, about the ocular disease, we have two factors to be treated. The first about the vascular element, or about this branch retinal vein occlusion. Should we go for laser or not? This branch retinal vein occlusion is not ischemic, and even if ischemic, it didn't develop neovascularization, so no need to do argon laser in this case. But for this cystoid macular edema, the second factor is the cystoid macular edema. For this cystoid macular edema, which will be confirmed by OCT, we can go for injection and follow up our patient every month to check for the improvement in cystoid macular edema. For how long would you like to follow your patient? Cases of branch retinal vein occlusion or central retinal vein occlusion should be followed up for 2 to 3 years for the possibility of conversion to ischemic type at any time. Okay, of course, this possibility decreases by time, so we decrease the follow-up intervals every year. We increase the follow-up intervals every year, but we should follow up our patient for at least 2 years and best for 3 years. The next case, colored photo of 60 years old male. Describe the lesion and what's your differential diagnosis? What would you like to do next to confirm your diagnosis? What are the investigations to be ordered? What's your treatment regimen? Let's go to the first question. Describe the lesion and what's your differential diagnosis? This is a colored photo of the right eye. You can see the disc edematous, swollen, hyperemic. You can see the blood vessels with extreme tortuosity and dilatation. The macula seems to be edematous and with hard exudates arranged radially around the center of the fovea, forming incomplete macular star. We can see flame-shaped hemorrhages, cotton wool spots, and hard exudates. My differential diagnosis, this is a case of malignant hypertension. This is the first differential diagnosis. And the much less probable diagnosis is neuroretinitis. As in neuroretinitis, we also have macular star and disc edema. But of course, this is a case of malignant hypertension because in neuroretinitis we do not have these vascular changes. This is a dilatation and tortuosity of the blood vessels. We do not have these hard exudates, cotton wool spots, hemorrhages. So the most probable diagnosis is malignant hypertension. What would you like to do next to confirm your diagnosis? The most important issue in this case is to check the other eye. Of course, if it is malignant hypertension, the picture will be the same in the other eye. And also about the examination, we would like to do something very important regarding the general examination in this case. is to check the blood pressure. Checking the blood pressure in this case is critical. What are the investigations to be ordered? About the ocular investigation, I will order OCT to evaluate the macula in this case. About the systemic investigations, we will ask for systemic evaluation by an internist. Okay, what's your treatment regimen? The only treatment in this case is controlling of the blood pressure, again in coordination with internist. Next question, a photo of 60 years old male. Describe the lesion. What's your diagnosis? Which stage and why? What's your treatment plan? Describe the lesion. This is B scan of OCT or structural OCT showing full thickness macular hole with hyperreflective cystic spaces on both sides of the hole. We can see here the posterior hyaloid with condensation of the vitreous at the center, forming what is called pseudoperculum. Our diagnosis is full thickness macular hole. Which stage and why? This macular hole is stage 4, evident by the presence of complete BVD. What's your treatment plan? The classic teaching, if this patient is seeing 6/12 or less, and the duration of this macular hole is less than 1 year, we will go for surgery. But by all means, we will go for surgery for this case, because this case carries very good visual prognosis. This from a surgical point of view. Our treatment plan is to doing vitrectomy with ILM peeling and putting the patient under gas like SF6 and performing face down position for 2 weeks. The success rate in these cases is exceeding 90%. Next case, colored photo of 55 years old female. Describes the lesion. What's your diagnosis? What are the investigations to be ordered? Systemic associations. How will you manage this case? Describe the lesion. Of course, this is a colored photo of right eye. We can see linear breaks in the at the level of the choroid, or exactly the proximal brain, radiating from the disc, and it is deeper than the blood vessels, meaning that this is at the level of the choroid. My diagnosis is angioid streaks. What are the investigations to be ordered? In this case, I will order OCT to evaluate the macula, as the macula may be complicated by CNV. And sometimes it could be involved by a small streak. Systemic associations, we use the mnemonic PEPSI, P for pseudoxanthoma elastica, E for Ehlers-Danlos syndrome, B for Paget disease, S for sickle cell disease, and I for idiopathic, as 50% of the cases are idiopathic. How will you manage this case? First of all, we should give our patient an amsler grid to check himself daily at home to detect the development of CNV, which is the most serious complication that may develop at any time. We will also advise our patient to avoid trauma, as these eyes are fragile eyes and liable for choroidal rupture with minimal trauma. And lastly, we will exclude the systemic associations, and the most serious one and the most common one at the same time is the pseudoxanthoma elastica. This will be in coordination with an internist. Next question. Colored photo and OCT of 12 years old female describes a lesion. What's your diagnosis? What are the investigations to be ordered? Which one is the most pathognomonic? What are the complications of this condition? About the colored photo, this is a colored photo of the left eye. You can see the disc is normal color and well-defined edge. The blood vessel seems normal. Background of the retina seems good. We have only yellowish lesion involving the center of the fovea, and it's about nearly 2 disc diameter. About the OCT, we can see hyperreflective lesion, oval or rounded in shape, at the level of the RPE, and this is corresponding to this yellowish lesion. Our diagnosis is Best macular dystrophy or juvenile vitelliform macular dystrophy. What are the investigations to be ordered? Which one is the most pathognomonic? We will order here electrophysiology, including ERG and EUG. And of course, the most pathognomonic one is the EUG, which evaluates the RPE. And here the pathology is mainly involving the RPE. What are the complications of this condition? The natural course of this disease, as it progresses from this vitelliform stage to the hypobion stage to the vitelliraptive stage, is decrease of the vision. There is deterioration of the vision as the patient getting older with the development of this disease. This is number one. Number two, this disease could be complicated by CNV, which could lead to macular scarring and further diminution of vision. Thank you.